Page number 228, Axenfeld-Rieger syndrome, Shields Textbook of Glaucoma, 6th edition. Axenfeld-Rieger syndrome terminology. In 1920, Axenfeld described a patient with a white line in the posterior aspect of the cornea near the limbus and tissue strands extending from peripheral iris to this prominent line. Beginning in the mid-1930s, Rieger reported cases with similar anterior segment anomalies but with additional changes in the iris including correctopia, atrophy, and hole formation. Some of these patients also had associated systemic developmental defects, especially of the teeth and facial bones. Axenfeld referred to his case as posterior embryotoxon of the cornea, and Rieger used the term mesodermal dysgenesis of the cornea and the iris. Traditionally, these conditions have been designated by three eponyms: Axenfeld anomaly, that is limited to the peripheral anterior segment defects; Rieger anomaly, that is peripheral abnormalities with additional changes in the iris; and C. Rieger syndrome, that is ocular anomalies plus systemic developmental defects. The similarity of anterior chamber angle abnormalities in the Axenfeld anomaly and the Rieger anomaly and syndrome led most investigators to agree that these three arbitrary categories represent a spectrum of developmental disorders. The overlap of ocular and systemic anomalies is such that the traditional classification is difficult to apply in all cases. Various collective terms have been applied to this spectrum of disorders, such as anterior chamber cleavage syndrome and mesodermal dysgenesis of the cornea and iris. As discussed earlier, the theories of normal development on which these names are based are no longer believed to be correct. The former collective term included the central ocular defects of Peters anomaly, discussed later in this chapter. Although some patients may have the combined defects of the Axenfeld anomaly or the Rieger anomaly and the Peters anomaly, the association is rare and the mechanism of the two disorders differ in most cases. The alternative term Axenfeld-Rieger syndrome was proposed for all clinical variations within the spectrum of developmental disorders and is now commonly used in the literature. This name retains reference to the original eponyms and does not depend on any theory of normal development, the understanding of which is still incomplete, nor does it require arbitrary subclassification of the clinical variations. General features of Axenfeld-Rieger syndrome. All patients with the Axenfeld-Rieger syndrome, irrespective of ocular manifestations, share the same general features: a bilateral developmental disorder of the eyes, a frequent family history of the disorder, with an autosomal dominant mode of inheritance, no sex predilection, frequent systemic developmental defects, and a high incidence of associated glaucoma. The age at which the Axenfeld-Rieger syndrome is diagnosed ranges from birth to adulthood, with most cases recognized in infancy or childhood. The diagnosis may result from the discovery of an abnormal iris or other ocular anomaly, signs of congenital glaucoma, reduced vision in older patients, or systemic anomalies. In other cases, the condition is diagnosed during a routine examination, which might have been prompted by a family history of the disorder. Ocular features in Axenfeld-Rieger syndrome. Ocular defects in the Axenfeld-Rieger syndrome are typically bilateral. The structures most commonly involved are the peripheral cornea, anterior chamber angle, and iris. Cornea. The characteristic abnormalities of the cornea is a prominent anteriorly displaced Schwalbe's line. This appears on slit lamp examination as a white line on the posterior cornea near the limbus. The prominent line may be incomplete usually limited to the temporal quadrant. In other patients, it may be seen for 360 degrees. In some cases, the line can only be seen by gonioscopy, although rare cases with other ocular and systemic features of the syndrome may have grossly normal Schwalbe's line. It is not uncommon for an individual to have a prominent Schwalbe line with no other evidence of Axenfeld-Rieger syndrome. This isolated defect is often referred to as posterior embryotoxon, the term originally used by Axenfeld, and it reportedly occurs in 8% to 15% of the general population, although it may represent a form first of Axenfeld-Rieger syndrome. In some cases, it is not usually included in the spectrum of anomalies. A prominent Schwalbe line may only rarely be associated with other disorders, including congenital glaucoma and iridocorneal endothelial syndrome. The cornea is otherwise normal in the typical patient with the Axenfeld-Rieger syndrome, with the exception of occasional variation in the overall size, that is, megalocornea, or less often microcornea, or shape of the cornea. Congenital opacities of the central cornea have also been observed in a few cases. The corneal endothelium is typically normal. By specular microscopy, the cells have distinct margins, although mild to moderate variations in the size and shape are commonly observed, especially in older patients and those with long standing glaucoma or previous intraocular surgery. Anterior chamber angle. Gonioscopic examination typically reveals a prominent Schwalbe line, although the extent of enlargement and anterior displacement of the Schwalbe line varies considerably among patients. Occasionally, the line is suspended from the cornea in some areas by a thin membrane. Tissue strands bridge the anterior chamber angle from the peripheral iris to the prominent ridge. These iridocorneal adhesions are typically similar in color and texture to the adjacent iris. The strands range in size from thread-like structures to broad bands extending from a Clark R or more of the circumference. In some eyes, only one to two tissue strands are seen, whereas others have several per quadrant. Beyond the tissue strands, the anterior chamber angle is open and the trabecular meshwork is visible, but the scleral spur is typically obscured by peripheral iris, which inserts into the posterior portion of the meshwork. Iris. Aside from the peripheral abnormalities, the iris may be normal in some patients with Axenfeld-Rieger syndrome. In other cases, defects of the iris range from mild stromal thinning to marked atrophy with hole formation, correctopia, and ectropion UV. When correctopia is present, the pupil is usually displaced toward a prominent peripheral tissue strand, which is often visible by slit lamp biomicroscopy. The atrophy and a hole formation typically occur in the quadrant away from the direction of the correctopia. In a small number of patients with the Axenfeld-Rieger syndrome, abnormalities of the central iris have been observed to progress. This is more often seen in the first years of life, but may also occur in older patients. The progressive changes usually consist of displacement or distortion of the pupil and occasional thinning or hole formation of the iris. In some cases, these progressive iris changes may be confused with those of ICE syndrome. Abnormalities of the peripheral iris or anterior chamber angle do not appear to progress after birth, except for occasional thickening of iridocorneal tissue strands. Additional ocular abnormalities in Axenfeld-Rieger syndrome. Many additional ocular abnormalities have been reported in one or more cases or pedigrees, although none occurs with sufficient frequency to be included as a typical feature of the Axenfeld-Rieger syndrome, and they may represent separate entities. These patients can have a wide range of ocular anomalies, including strabismus, limbal dermoids, corneal pannus, cataracts, congenital ectropion UV, congenital pupillary iris lens membrane, peripheral spoke-like transillumination defects of the iris, retinal detachment, macular degeneration, chorioretinal colobomas, choroidal hypoplasia, and hypoplasia of the optic nerve heads. Glaucoma. Slightly more than half of the patients with Axenfeld-Rieger syndrome develop glaucoma. The glaucoma may manifest in infancy, although it more commonly appears in childhood or young adulthood. The extent of the iris defects and iridocorneal strands does not correlate precisely with the presence or severity of the glaucoma. However, the high insertion of peripheral iris into the trabecular meshwork, which is present to some degree in all cases, appears to be more pronounced in those eyes with glaucoma. The proposed mechanism of glaucoma in these cases relates to abnormalities of the trabecular meshwork and Schlemm's canal, discussed in the histopathological features and theories of mechanism section. Systemic features. The systemic anomalies most commonly associated with Axenfeld-Rieger syndrome are developmental defects of the teeth and facial bones. The dental abnormalities include a reduced crown size, that is microdontia, a decreased but evenly spaced number of teeth, that is hypodontia, and a focal absence of teeth, that is oligodontia or anodontia. The teeth most commonly missing are anterior maxillary primary and permanent central incisors. Facial anomalies include maxillary hypoplasia with flattening of the midface and a receding upper lip and prominent lower lip, especially in association with dental hypoplasia. Hypotaylorism, telecanthus, a broad flat nose, micrognathia, and mandibular prognathism have also been described. Anomalies in the region of the pituitary gland are a less common but more serious finding associated with Axenfeld-Rieger syndrome. A primary empty sella syndrome has been documented in several patients, and in one case of congenital paracellular, an arachnoid cyst was reported. Growth hormone deficiency and short stature have also been described in association with entity. Other associated abnormalities include redundant periumbilical skin and hypospadias, oculocutaneous albinism, heart defects, middle ear deafness, mental deficiency, and various neurologic, dermatologic, and skeletal disorders.